I'm Dr. Michael DeTola.
And I'm Megan Strong.
Put down the handpiece, step off the rheostat. That hygiene check can wait. Stop condensing that amalgam with your thumb. Get your Hot Pocket out of the autoclave. Could these bib clips be the filthiest thing in your dental office? No, besides me.
And how much would you pay for a German dentist who gave the finger to Alvin and the Chipmunks 2 the Squeakquel?
And did Megan try to shave her legs with home-baked cookies?
And the AGD shows us the shocking similarities of the effects of meth use and toothpaste that Willy Wonka would have loved.
In today's Case of the Week, we take a cheeky look at our inner Tanya Harding gets worked over like a heavy bag at Gold's Gym.
And what would you do if you were in prison with only 5 teeth and Justin Bieber?
That and more on today's Chairside Live. Oh, hello and welcome to the Centennial edition of Chairside Live. I had to look that up. Do you know what it means?
It means 100.
It doesn't mean 100. Is it right? It's the 100th episode. We were going to go outside and do something special for it. However, it is on this day 100 degrees outside in Southern California. And you're not supposed to be outside if it's over, say, 95.
Right. Well, I'm, regardless of, it is so hot outside. And then you bring in into the equation the fact that I'm 31 weeks pregnant today.
Right.
Just myself and heat, we just don't mix at this point.
Right. People may want to know we actually carried you in one of those large igloo coolers from your car to the building to keep you cool and keep your core temperature down.
That's not true.
You're sitting on a block of ice.
I wish.
You're going to deny that? You're melting it as we sit here. So the 100th episode, and it's going to be a good one. We've got an interesting case of the week. We are continuing our springtime tour of the partial denture department. And today we look at another common problem that we see in the partial department. I was going to say mistake, but it's really not a mistake. It's where we have compromised space between the arches and we don't have enough room for acrylic denture teeth, which aren't that strong. And so one of the ways that our technicians are able to deal with that is through the use of composite facings, which not only are stronger, can fit into a smaller space, but look fantastic. Let's take a look at that now. I was walking through the partial denture department the other day and I ran into the manager, Jerry Lord, and I asked him to show me what are some of the most common problems that his department sees. And he reached over and he grabbed this case and he said, this is one we see all the time and I want to show you a solution we have that he thinks is a great solution, and I have to agree with him. This certainly presents some challenges relative to setting up teeth 7, 8, and 10 here. We want to put something in there that's going to stand the test of time, is going to function and not, fall apart in a week or two. And we've got a really tight bite here, and we don't have room for mesh or relief under the mesh, a denture tooth and some acrylic to be able to fit in there, and the guide planes that we might need as well. So we're even limited in placing like a metal pad with a post centered in the middle for denture teeth. And back in the 1970s or 80s, a doctor would prescribe Steele's facings, and they were good for the time, but I think Jerry's got a better solution for what he does now. He basically gets a refractory model, a waxing model, and has a technician wax up number 7, 8, and number 10, and then the technician removes those, and it gets sent to a technician who's actually going to make the partial framework, and that's a specific team of partial denture anatomy specialists. And after it's done, it goes back to the technician who waxed the teeth, the aesthetic specialist, and then they opaque the metal substructure, and then they apply a composite facing. And so as you can look and see, the occlusion itself, the lingual is in metal, and then the opaque and the composite is on the front, and that's pretty darn nice looking. I mean, I think we're all pretty pleased with how composites look. This is premise from Kerr, that the lab uses, so it's a high quality composite. The exact same composite we would use on anterior teeth in the mouth, so it's no wonder it looks so good. I think it looks as good or better as almost all denture teeth that I've seen. So this composite facing idea is fantastic. And as we look at the design, let me pop this into place. You can see an interesting feature here. As long as we're being cosmetic and using composite, you can see that we've got some pretty short arms here on these two clasps, these little snubber clasps, as we like to call them. And you can do that on the buccal if you are able to get good mesiolingual retention. So really you can see the majority of this clasp is on the lingual, engaging an undercut on the mesiolingual. And that's going to oppose the shorter buccal little snubber clasp here that hopefully won't cross the midline of this tooth on the facial to kind of keep it hidden like it is here. And you can see again engaging a mesiolingual undercut here that will oppose the little snubber clasp over here. You need this clasp on this side to oppose this for retention. You can't get away with just putting this lingual clasp here and having nothing on the buccal, but you need to make sure that there is in fact some undercut on the mesiolingual, and there has to be not too much undercut on the distal lingual. And so really this is something that needs to be taken care of at prep time, where you would come in here on this tooth if you wanted to do a snubber clasp on this tooth, for example, and you would flatten this off, recontour the distal of this, make sure there's no undercuts, and then if there wasn't an undercut on the mesiolingual, you'd have to go in and create one by creating a taper right above the gingiva, the free margin of the gingiva, so this clasp could in fact engage that on the mesiolingual, allowing our technicians to put these very short snubber clasps there. Certainly that's going to be a lot less apparent from the front than a lot of other clasp types. It's really not recommended to do this type of lingual retention when you have a free end on the denture, but here we have no teeth behind it, and here we have it's tooth-borne on this molar as well, and so we're safe doing this. But we really don't like to do this if in fact it's going to be a free end. And I happen to see one other case that he had along those same lines, and I'll take this partial out so you can get an opportunity to see over here on this side. Again, from number 12 to number 14, we need some teeth here. And again, we just don't have the room to retain denture teeth. And so again, you know, for the room for the mesh, the relief under the mesh, the acrylic, and the denture teeth themselves, if it's attempted, it's just going to break right out of there. And again, you can see by having the occlusion completely in the cast metal, and then again the composite being bonded to the outside, there's so many undercuts in this metal that the composite's bonded to, that this is so much more resilient and so much stronger than if denture teeth were to be bonded here. It's kind of like the way on a direct composite, for example, you can have undercuts in the preparation, and you can put direct composite like this in and cure it into place, and it'll never come out because of the undercuts. And that's kind of what this is like. Versus if we were to bond a denture tooth on here, you can't have undercuts, and so it's kind of like putting an inlay in that same tooth. And as a result, with an inlay, you have to have a prep that's not only not undercut, but it's flared, and so the retention's not quite the same as when you can have those undercuts. So as this goes into place, again, by having the patient now occlude on those metal occlusals and making sure that when they come out in excursive functions, they're not hitting directly on that composite. This is a great way to not only have very aesthetic teeth, in fact, you should consider these composite facings almost any time you've got anterior teeth on a partial, but in addition to being very aesthetic, they allow us to go into areas where we don't have a lot of intraocclusal clearance and be able to place some nice looking teeth in an area where previously we simply would not have room for acrylic and denture teeth. Here's another case that features lingual retention, and a doctor with an open mind willing to take some advice. He did some great rest preps here, as you can see, on the occlusal of these teeth, and patients missing teeth 1 through 4 and tooth number 14. So the doctor's RX actually prescribed an I-bar clasp on tooth number 5 and a circumferential clasp on 12. and on 15, and also asked for the use of a horseshoe major connector. And the partial denture designer noted that there's a mesiolingual undercut on tooth number 13. So the designer suggested that we use that for lingual retention, and then a buccal snubber clasp to reciprocate that over on the buccal. And again, that lingual clasp is going to work pretty well because there's really no, as you look at this, there's no undercut on the distal of that tooth. The designer also noted that the patient has a significant prominent rugae that needed to be relieved, and the tissue undercut presented would need to be blocked out, and that would lead to a really bulky major connector, as you can imagine, kind of sitting over that. So the designer suggested a palatal strap instead, and you can see it's going to stay clear of all these palatal rugae in the front and the anterior portion of the palate. You can see where it's been marked back here for that palatal strap. And so the doctor said, yeah, it sounds great, go for it. And here's what that looks like when it's placed on the model. And again, you can see that with the undercut present on the mesiolingual, that allows the use of that little snubber clasp. And there it doesn't even come close to coming halfway around. And so from the anterior, we're probably not going to see much of that at all. This is an older patient. This is a patient in their late 60s. So an I-bar clasp like this actually becomes almost an aesthetic clasp in a sense, because as you've no doubt noticed, as patients get older, their upper lip tends to hang down more because of gravity, and so does their lower lip, and they start to show less and less of their maxillary teeth and more of their mandibular teeth. So it's pretty good chances that the lip's going to be hanging down past that I-bar. So it's aesthetic in older patients, and it's kind to teeth like this one that already has some recession here, because when the patient loads this and pushes down on that, and that clasp has a tendency to move towards the distal and disengage from the tooth, whereas a typical circumferential clasp, if it was coming around this way, as the patient loads the partial, it moves in an occlusal direction and wants to rotate the tooth out of the socket. So the I-bar can actually be aesthetic, even though it looks like a lot of metal. And on another case, again, this is a doctor who's done some really nice rest preps here, if I can get this off. And he had written on the RX for a circumferential clasp on tooth number 3, an I-bar on 6, and a crib clasp over on 12 and 13. And when the designer surveyed the model, he saw an option again to kind of reduce the metal display on 12 and 13 by modifying the clasp design. And so just like with that last patient, we're going to use the mesiolingual undercut on tooth number 12, and then a short buccal snubber clasp to reciprocate that. It's kind of like retention on a crown prep. You know, you can't just have a flat plane on the facial here and call that retention. There has to be a flat plane in the gingival third here that's about as parallel or parallel to the plane over here on the facial to get some mechanical retention for a crown. And so we always need to reciprocate with partials as well. We can have a clasp here, but then we need something over here to reciprocate that to create the actual retention itself. And then on number 13, they used a really aesthetic clasp, which is really nice, where the clasp actually originates. You can see the rest prep there, where the doctor originally thought there would be a crib clasp there. But you can see that the aesthetic clasp on the distal of 13 originates from the mesial rest and then wraps around the lingual to engage the distal undercut. And that really looks fantastic. And so as we look at that, we do have that little snubber still over here, but then we have nothing on 13 because that clasp is completely hidden. And typically that would be waxed like this. The crib clasp would have this and then the two circumferential clasps going around it. And this way we just have the short snubber on the first bite, and on the second bite we actually kind of have the hidden clasp that goes from the mesial rest around the lingual onto the distal surfaces. So even though clasps by definition, because they're metal, may appear unaesthetic, or we might always think of them as unaesthetic, give the designers a chance. If you don't have an idea in mind, have them create for you or ask them to create the most aesthetic way to be able to use metal in here. You may have to have the patient back one more time and create some undercut on some of these teeth or remove some undercut on other parts of the teeth. But as long as you're willing to do that and work with the designers, very often we can give you a design that you're going to be happy with. And more importantly, the patient's going to be happy because instead of seeing a bunch of metal, they may not be able to see any metal at all.
And now let's go to a segment we call Viewer Mail. This week's viewer mail comes to us from Dr. Ernest Yamani, and he writes, I have a question regarding the safety of doing a minor gingivectomy around a tooth that has been restored with either an e.max or Bruxer crown. I have a case that has been restored with an e.max crown and has experienced some tissue growth that has created a tissue height discrepancy with the adjacent tooth. I'd rather not use cold steel, but I'm concerned about using electrosurgery with the possibility of contacting the crown surface. Please advise.
Please, a cold steel. I like the sound of that.
Right.
For a scalpel. I mean, it always sounds nice to say cold steel. Well, it's an interesting question, and actually the first time I've been asked that, but it makes a lot of sense if you think about it. For example, if you look up zirconia on the periodic table, you will see that it is, in fact, a metal. But when you look up zirconia oxide or zirconia dioxide, what we're making Bruxer crowns out of, it is in fact a structural ceramic, and it's no longer a metal. If it were a metal, when we made it into a bridge, we wouldn't have to worry about that rule of 27 and having a Bruxer bridge break if the connector's too thin. That's why I've mentioned on many occasions that I still use PFM bridges to replace lower first molars, for example, because you can make a metal connector for a PFM bridge incredibly thin, not only vertically but horizontally, much thinner than you ever could with Bruxer, the zirconia dioxide. So the zirconia dioxide, or the oxide of almost any metal, is in fact a structural ceramic. So yes, you're safe to use an electrosurge around an e.max crown or around a Bruxer crown as well. In fact, it's the same way when you look at lithium on the periodic table and the disilicate of it being a structural ceramic as well. However, although you can use it, as you mentioned, you'll be fine, may I suggest in this world of implants and working around uncovering them and trimming tissue next to metallic things like an implant abutment perhaps to uncover it or get an impression coping on, you might consider the purchase of a diode laser. They've come down so far in price over the last 5 to 10 years. The one that I have, the Picasso Light from AMD Lasers, which is now part of Dentsply, I believe is selling for less than maybe $2,500, maybe as low as $2,000 at the CDA show this weekend here in Anaheim. They'll often run show specials, and I've been so happy with that device. Like you, I used to have an electrosurge, and I love how quickly they cut. I mean, it's just right through tissue. In fact, that might almost be the downside as well as you're getting used to it and learning how to use it, is that you can overcut. But of course, you can't come anywhere near implants. You wouldn't want to come anywhere near an amalgam or anything metal that happened to be maybe a titanium bar that was in the mouth. You've got to stay away with the electrosurge. Whereas with the diode laser, you can come right up to the metal, in fact, even touch it, and there's not any issues. The downside is that it cuts a lot slower, and when you're used to an electrosurge, it really takes kind of a mind shift to get used to that. So when I started using a diode, I noticed that whereas I could go with an electrosurge and just make a quick cut to do a minor gingivectomy like you're talking about, with the diode it was almost like peeling layers off of an onion, where you're going around several times, taking a little bit at a time as you go. So you're more carving it in a sense than cutting it. And it tends to be kind of a safer way. There's more safety built into it just because it's going so much more slowly than it can be. Another thing that I'd like to see is very thin tips on diode lasers. Hopefully we'll get to the point where we've got maybe 100 micron or less tips, just needle sharp tips on diode lasers, like we can do on an electrosurge, where we can take a loop, cut the top off, and then really just take a stone and really polish it to a point and get a thin point and be able to go in and draw with an electrosurge. But when you consider both of them, if somebody asked me which one should I get, I would have to say the diode laser, just because of the fact that with all the implants that are being placed and restored today, we need something. If we're just going to have one item that's going to work around everything, it would have to be the diode laser. Of course, there's nothing wrong with having an electrosurge and a diode laser as well. I've got an electric handpiece that I've used for years, and I recently got a new Cavo turbine, an air rotor, a master torque, that I find works great for other situations too, like getting to the back of the mouth where the electric handpiece doesn't quite want to fit. So there's nothing wrong with having both of those technologies, but great question. You have the distinction of being the first dentist to actually ask it, and he asked it on the 100th episode. That's pretty cool too.
Of course, and so with that special circumstance, we have a one-of-a-kind photo of actually another big milestone in Chairside Live history, the 50th episode.
Right. We like to have a big party every 50 episode. I just noticed I'm holding my mug the wrong way.
Bless your heart. It's okay.
It's blank. I'll draw the picture in later before we send it out.
Yeah, we'll sign this and send it out. And yeah, I think it's pretty exciting. There's balloons and everything.
And the question was about e.max, so I'm going to also send you a Bruxer adjustment polishing kit. I know that sounds weird, but the same diamonds with the small particle size that you'll see on here, the blue stripe diamonds with diamond particles anywhere from 5 microns up to, say, 60 microns. These Bruxer adjustment diamonds work very, very well on e.max, and the polishing tips that are in here, the cups, work very well on both those monolithic materials as well. So just in case the gingivectomy doesn't solve the aesthetic issues and you need to cut it off, the same burrs that you use to adjust and polish Bruxer and e.max are the same ones that you use to cut it off as well. So we'll send that along with the anniversary picture. Thank you so much for the question. And do you have any 100th episode news?
I do. Let's check it out. In what probably looked like a scene straight out of Hitchcock's The Birds, a Texas man was recently attacked by a bird in the parking lot of an automotive shop. During the attack, the man fell down, lost a tooth, and was knocked unconscious. It started when out of nowhere, the bird swooped down and started to attack him. The man ran, and the bird chased him, hitting him and knocking him to the ground. He ended up with open wounds, a missing tooth, and had to get stitches on his face.
You know, it was interesting. You told me not to watch the video until we did it, so I'm going to pull it up. Pull it up right now. But hearing the headline of the story was that the bird knocks the tooth out, but then you made it sound like it's when he gets knocked down that his tooth comes out. So let's take a look at this now.
Okay.
He's running. I see the 3 birds and
down. I mean, that's a tumble, right? That is. I don't. He doesn't get his hands out in front of him. No, I think he hits face first. Right. So the bird hits him and he's down, and then I think that's when, upon impact, his tooth came out.
So those aren't drones. Those are birds.
Those
we know
are
that
birds.
For a fact.
Yes. Yeah. And apparently, there's been other attacks. This one being the worst of its kind, but there was other attacks of those same birds in that parking lot. So
I feel like I've watched enough action movies where I know that one of his mistakes was he failed to run serpentine.
Right.
That always seems to work in an action movie. Here's actually, I just noticed, if you scroll down a little on the page, you can see the bird itself.
Right. That, to me, you know what? I pictured
ravens when I saw the video.
Me too, but I think that this might be a photograph of, they are saying, the shop owner and other people that have been around this store parking lot, they're saying that they believe the reason why the birds are attacking is because there's a baby bird in the parking lot who cannot fly, and so the older birds are protecting the bird. So I think that might be the baby bird. Let's hope. Okay. Because if not, that's a pretty powerful bird.
Yeah, that seems pretty small and pretty bionic. But I've never been running, being chased by a bird, and it might be, I don't even have the cushion of hair.
Right.
And so it might be, if I got pecked once, I might go down like an Italian soccer player too. Right. You know, like it always looks like they got hit by an assassin in the stands when they grab their leg and go down, and they have the magic spray put on back on their feet 3 seconds later.
Right. And it made me think a little bit of, did you ever see, bless his heart, in the news a few years back when Fabio was on the roller coaster and the bird, and he had the whole bloody mess?
And the goose, hit him in the face.
So yeah, people were saying that, the witnesses were saying that he was all bloody and it looked horrible.
I would like to check Netflix and see if the rentals of, or the viewings of Alfred Hitchcock's The Birds has gone up since then.
Possibly.
But the bottom line, I think, is wear a Glidewell Play Safe anytime you visit an automotive parts store. That's what I hear you saying. In Texas,
That's exactly what I'm saying.
Anything else?
Yes. The NFL Players Association and a dentist specializing in sleep and jaw disorders recently joined forces and screened NFL players and former players for sleep apnea. Because of their size and neck girth, 89% of NFL players suffer from some sort of sleep disorder. The Players Association has teamed up with other health organizations to test former players and to increase the awareness of the condition. The program began in October 2012 and hopes to promote health and weight management among former NFL players.
I love this idea, and after Reggie White passed away and obstructive sleep apnea was listed as one of the causes, he had a CPAP machine, which is kind of the gold standard, in obstructive sleep apnea treatment, and just struggle to wear it. Really, some people really have a hard time sleeping with a mask on or the nasal cannulas in their nostril. It's not totally comfortable. Then again, I met a dentist this weekend who's been sleeping with it for 15 years and has no problems and says, I feel claustrophobic with an oral appliance in my mouth. I feel better with the mask on. But Reggie's wife, after his death, really kind of got this started, and it got some momentum, and then it slowed down again. I think it's fantastic because anytime you have somebody like an NFL player or Michael J. Fox, with Parkinson's, just somebody high profile like that, it's really all of a sudden you take a disease or a condition that not a lot of people knew about, and it gets it out in front of other people. A lot of doctors who deal with obstructive sleep apnea think that John Candy may have had it. He died in his sleep, but it's not always listed as a cause of death because it's a contributing factor, but not necessarily the primary cause. So I think this is great. When you look at the NFL players, they have just about every warning sign. They're male. They're overweight, neck size over 17 inches. Mine's 16, so it's not that much bigger to get to 17. Some of those guys, must have huge necks. All that tissue, and you just know they walk in the door and you look at them and they look like an advertisement for obstructive sleep apnea. And a lot of it's weight. The snoring that I used to do a couple years ago when I weighed a lot more is gone now that I lost the weight. So there couldn't be a better group to try to educate and try to get involved with this than those players, because they are as at risk as any other group, and they're also much more high profile than any other group as well. And so it stands to really be good for the public to be able to see these NFL players willing to do this.
Definitely. And to me, the statistic was shocking that 89% of them.
Right.
Like, that's just incredible. And so I think that if they can get the word out, not only to just regular citizens who look up to the players, but also to the other players who are actively currently playing, and to get those preventative appliances now, I think really would be a move in the right direction. And
it's pretty much everybody but the kickers and the wide receivers and maybe the quarterback. All those linemen where you just look at them and you go, that guy's an athlete.
Right.
But you realize he's not only super muscular, but he's just an immovable force at,
You're
300 pounds.
Pretty far past
Yeah,
him.
it's tough to push him 4 inches backwards. And I think it's great because, I see at my kids' high school, now all of a sudden when I look at some of the offensive and defensive linemen on their team, they look just huge compared to what the kids were, 35 years ago when I was in high school. And so they're getting bigger and they're gaining more weight because they want to get college scholarships. And I know this is a problem that, besides the NFL players, plagues the college ranks and even the high school football ranks as well, too. So it's neat to see the NFL retired guys get on board.
Yeah.
And hopefully this message, kind of like with mouth guards, will trickle down and we'll see more football players, if they're not able to lose the weight and get the neck size down because they're playing, at least deal with it with an oral appliance or a CPAP device at night so they don't die.
Yes.
All right, well, that about wraps it up for the 100th episode of Chairside Live. We appreciate you being around for the last 100 episodes, and to all of you who have written in and had comments and had viewer mail that's been read, thank you so much, or made requests for cases of the week. We love it, we encourage it, and we hope to see you in the next 100 episodes as well. So on behalf of myself, Megan, the whole Chairside Live crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time for the next 100.
That's right.
DJ Jimmy K. Now let's go for the 100th time to the case of the week.
Viewer mail. The case of the missing viewer mail. Encyclopedia Brown here.
The case of Megan's missing brain. Okay.
For the 100th time, you're welcome! God! For the 1,000th... I've asked you 1,000 times to pick up those clothes.
Right, that, to me, well, ooh.